All right, so I'll get us started. Hi, everyone. Thanks so much for joining us here today. I'm Claire Pickering from the membership team at AFA, and we're just here today to give you some exciting updates on Medicare advocacy and how we have, I guess, built built out a practice at Umbra and have gone live for Original Medicare in all 50 states. So here to just sort of share updates, what we've learned so far, what we're doing, how it works, so you can decide if this is something you want to add to your practice. I'm going to turn it over in a second to Deb Gordon, who's the director of AFA and founder of Umbra. And then I guess we'll have time for some Q&A. We have a pretty good sized group today, so I'm going to ask folks to put questions in the chat, and I will be monitoring that so I can jump in and read those out for you if you have questions. And Deb won't mind if I interrupt, I think. So, all right, I'm going to go ahead. I'm going to turn my I'm going to unpin myself and let you take it, Deb.
Okay. Well, thank you. Thanks, Claire. Thanks, everyone, for being here. Good to see folks. As Claire said, I'm Deb Gordon. I'm the founder of Umbra and the director of AFA. We also have some other teammates here from AFA Umbra. Abby Basnight is here. She's our COO, and Jennifer Keene is our head of growth, our chief growth officer. If I'm missing someone, shout out. Hopefully not. And we know some of you are AFA members and you're with us a lot, and some of you are probably new to AFA or Umbra, and you're curious, and we're glad you're all here. So Claire, definitely chime in with questions that you're seeing. I'll go through an overview. We'll explain what we're doing, how things work. We know that folks may be at differing levels of familiarity. So forgive me if it's feels remedial, or if I'm going too fast, or it's, I haven't addressed something you're curious about, just chime on in. We'll use the chat, as Claire said. So on the next slide, we'll go through kind of what is the Medicare navigation service? What are the services? Why do we have them? Who can provide them? Things like that. But I think the starting point that's really important is that I think folks know that Medicare introduced reimbursement codes in January of 2024 to support patients with complex needs. And what was at the time called social determinants of health, now often referred to by the current administration as upstream impacts on health. But the point is non-medical barriers to care. And there were already, I just think it's worth noting, there were already care management codes, and those continue to be available. But many of the care management codes were reserved for, I think, RNs or above. And these codes are specifically designed to be delegated to advocates, navigators, community health workers. I'll say more about that in a slide or two. But first, let me just kind of level set. There are about 70 million people on Medicare. About half of those people have original Medicare and half are on Medicare Advantage. I'm using very round numbers, but that's about the shape of it. And there are about 13 million people of the 70 who have both Medicare and Medicaid. So Medicare, as I think folks know, is a program, health insurance for older Americans or people that it's not just citizens, it's people who are here legally, who have worked for some period of time and paid into the Medicare fund. And it also covers people under 65 who have certain conditions or disabilities. Medicare and Medicaid dual eligibility is for people who meet the Medicare qualifications and income thresholds for Medicaid. Part of the need for these services, if you know folks in this population, there's a lot of need, but the data supports that as well. 80% of people on Medicare have at least one chronic condition, and 2/3 have two or more. So the clinical complexity is pretty intense in the Medicare population. There's also a financial need. So about 1/3 of Medicare beneficiaries report difficulty affording healthcare. That's a lot better actually than other populations because Medicare is a pretty robust and comprehensive insurance program. But even with that, what is arguably the best or one of the best sort of coverage setups to be in this country, still more than a third feel the strain of healthcare costs. On the next slide, I'm going to say just a little bit more. I mentioned there are care management codes. I don't have all those details on here, but the crux of what we're talking about are two sets of codes that are kind of overlapping, very similar, but are intended for slightly different purposes and have some nuanced differences to them. So principal illness navigation is for people with at least one serious chronic condition. So it's sort of defined there's a definition of chronic. It's expected to last at least 3 months or more. And the condition puts the person at risk of mental or physical health decline or hospitalization or death. And then the services might be things like care coordination, setting up appointments, finding the right specialist, facilitating patient doctor communication or patient family communication, identifying condition specific resources or education, things like that. On the other side, community health integration is designed for people, excuse me, with non-medical barriers, like I said, the social determinants of health that specifically put someone at risk or are either currently interfering or are likely to interfere with that person's diagnosis or treatment. So it's meant to be um, it's meant to be for people who have blockers, like they're not getting the best care, they're not in optimal health or health care access because of a non-medical barrier. And examples of these services, there's a lot of overlap. There might be care coordination, there might be communication facilitation or researching resources, but on the principal illness side, it's meant to be specific to the condition or conditions that a patient is experiencing. And on the community health integration side, it's meant to be or it's thought to it's designed for more of the general um you know I need transportation but I don't have access to a car, I can't drive, or I don't live on a bus route or something like that. So it's still in service to helping people get the care they need, but it can be more explicitly non-medical. But there's a lot of overlap between those services. um who can provide these services? This is really, I think this is really important to understand, and part of why it's a big lift to set up these services. Excuse me. So it starts, and I'm going to show in another slide, I'm going to show kind of a process flow or a process map, very high level. But these services start with, oops, with a visit to a physician or another licensed provider who is um, credentialed and sort of deemed eligible by CMS to provide these what's called initiating visits. That provider is the sort of billing provider, billing practitioner, and they must be in the US on US soil when they're furnishing those services, and they actually must stay with the patient. So what happens after the initial visit remains under the supervision of that provider. So that provider kind of is meant to stay with the patient. Um, the services are then delegated to or performed by auxiliary personnel, also must be physically located in the United States, states or territories. And there are some states with specific criteria of, you must at least meet this community health worker certification standard in particular states or that state's certification standard. But in most states, the qualifications are some form of training or competency in patient advocacy, care coordination, system navigation, and even patient and family dynamics and communication. So there, I think calling this a process map is maybe generous. It's just a quick little flow to outline what I just said. So a patient who's on Medicare needs help navigating care in some way, needs help accessing or optimizing their treatment, diagnosis and treatment. A licensed provider conducts an assessment in an initiating visit. It can be a telehealth visit. That initial visit is designed to assess the patient's eligibility for these services. So, do they meet those criteria I mentioned on an earlier slide? Do they have a chronic condition that's serious and putting their health at risk? Are they facing non-medical barriers and things like that? So that's what the initial initiating visit is for. Um, if the provider determines that the patient is eligible for these services, they then can refer or delegate the to a patient advocate or navigator, care coordinator, community health worker. Here on this slide, people have different feelings about different terms. We typically default to patient advocate or navigator, but we're talking about the auxiliary personnel. The auxiliary personnel then meets the patient as well, building on the provider's initial visit, um, building on whatever the patient has already shared about their needs, and does an in-depth assessment and care plan. That, if you're a BCPA or you're a seasoned advocate, that's the kind of activity you would be familiar with. We've modeled those stages in the process on what we would expect a BCPA to be able to do. Um, the provider kind of signs off or approves the care plan, the patient consents to the care plan, and the advocate furnishes the services. So whatever that may be, I need help with X, the advocate, works the plan. The patient and advocate work together to set the patient's goals or identify the patient's goals, and the care plan is meant to serve or address those goals and objectives. As I mentioned before, the supervising provider continues to be in the loop. It's really under the auspices of that provider that these services can occur. Um, Care plan updates get approved by the provider, and if there's any need for a clinical escalation or clinical input, the provider is there to make sure the patient and the advocate have what they need um, to safely execute the care plan. So Claire, uh, not to bury the lead, Claire led with this. It's sort of funny, we don't need this map anymore, but for a long time or many months, we were kind of updating the map as we opened a new territory, and now we're everywhere. So maybe the next time we present this, we won't need a map, but I still find it pretty cool because I remember when it was blank. So we now can say yes to a patient, serve a patient in all 50 states and DC. We're working on Puerto Rico. And we we have accepted patients, served patients, billed for patients. So we've got an initial the initial wheel is turning. Let me say that. So we are still in the, I would say, relatively early days, but we're open. We're open, we're live, we can do and have done and continue to do all of the stages of this process that I mentioned. I say that because at a point, maybe last year sometime, not this time, not even a year ago, we were here saying, we're building this and we're adding places and please join us. And now I still want to say, please join us because we're very happy to expand our platform and welcome people in. But it's now a going concern, not just a twinkle in our eye. We are really committed to it, our roots. We're here for independent patient advocates. Obviously, that's what AFA is all about. And so we are, uh, you know, always thinking of ways to enable and support independent advocates to take advantage of or capitalize on these services. Not everyone wants to, and that is completely fine. We completely respect that our field takes all kinds, and we're not pressuring anyone or expecting anyone to join our platform, but we are designing with advocates in mind as well as patients. So if you have clients that you have had to say no to because they're on Medicare and they can't afford your services, or you have clients who you're serving pro bono, but they're on Medicare and you could capture some amount of reimbursement for it, we're here to support you. And that's, sort of from one patient at a time to you want to put a whole practice into our platform and serve a whole bunch of Medicare patients and build your own uh, services, we can support you in that way as well. So as we build the practice on the Umbra side, we are also keeping in mind how can we make this almost like a shared resource because of who we are. We really want to make the most of this infrastructure. It would not be feasible for most people, most independent advocates, to set this up on their own. Certainly nationwide is a very big lift, but even in one state, you need a provider, you need a provider practice. In most states, a doctor needs to own the practice. That doctor and the practice and the need to enroll in Medicare, then you need a billing system, you need an EMR, you need compliance. So it's a lot. Somebody said, "Oh, it sounds like a lot of work." Someone said this to me recently, and I think I might have said it is an ungodly amount of work to get to this point. And we look at our purpose and our mission as um, supporting this community. So again, you can participate, you can not participate, you can participate passively and receive referrals from us, but you can also kind of consider our network an asset that you can tap into. On the next slide.
So
Um,
do you want to answer a couple
oh,
questions
sure.
that I maybe we could fit
Sure.
in here? Some questions
Yes.
about how it works in terms of like who does the advocate work for? Jan is asking is Umbra a TPA?
Hmm.
Um,
That's a good
like
question. I wouldn't call us a TPA exactly, because that has, I think, specific meaning, but it's not a bad analogy. Like it's a good analogy. It's not exactly the structure. But so the advocates who work with us are independent contractors. So you work for yourself under contract to us. The provider provides general oversight or general supervision. That's per the CMS requirements. I do think that is a little bit different. That is certainly different from working for yourself with nobody else involved. Uh, we have a contract and we have rules and compliance and standards and expectations and policies and things like that, which are all designed to first and foremost, adhere to legal and regulatory standards, and also wherever possible, which is pretty much, I think, everywhere, we design our policies to align with the BCPA standards and ethics. So you work for yourself in a framework, and technically the patient care is supervised by the provider.
and the providers are they're Umbra providers, correct?
Correct.
Right? Someone's
Correct.
asking if the providers, and then so Mara is asking if they need to find their own supervising provider. The answer is no.
No,
We we can provide the provider.
exactly. If you have a relationship with a provider but you don't have the billing infrastructure or the EMR or the charting or what have you, you can you can be a dyad and bring your provider to the platform. We contract with the provider, we enroll them in our practice. We can bill basically for them and keep you two together. But if you don't have that, which I think a lot of folks do not, we we have that. That's sort of that's the that's what the map represents, that we've built that network and enrolled in with CMS.
I'm trying to find questions that apply, like we're on the same line here.
Yeah. TPA stands for,
Ian is
oh,
asking, oh,
sorry. Go ahead. You go,
somebody
Claire.
answered it. Third
Yeah.
party, third third party administrator.
Third party administrator for
Sorry,
folks who didn't see it.
Ian had a, let me try. Ian is asking, it's my understanding the physician initiates this process and requests a patient advocate. So like sometimes, right? But do you want to say how like folks would get into the workflow?
Yeah, yeah. So in a practice, in a medical practice or a hospital, oh, actually it wouldn't work in a hospital, but in a clinic setting, let's say, maybe the physician would say, this patient needs help and would refer the patient to would basically do that assessment right there. And, in the moment they are seeing the patient, they're saying, oh, this patient needs help. I'm going to refer to an advocate or to a navigator. But it's sort of a technicality that CMS first to CMS, the process starts with the physician or the nurse practitioner or physician assistant who says, yes, upon, doing an initial visit, I deem this person eligible. That to CMS is the first step. But how patients get to that first step could be any number of things. The patient could call and say, I need help. Can you help? The An advocate might say, I have a patient who, or a client who's on Medicare, I think they would benefit, and refer to that initial visit. So it's sort of like the CMS process begins at the physician or the nurse practitioner, but in real life, the patient could be identified in any number of ways by their own hand raising or, uh, a service provider, a community resource, a family member, or their physician could say, hey, this patient might need these services.
So for a question from William, he says, as a licensed physician starting my patient advocacy business, for someone like him, what parts of the model actually fit within Medicare reimbursement and what parts would still need to stay private pay? Does reimbursement
Mhm.
only work if I'm functioning as the treating physician with a care plan and supervised team rather than as an independent advocate? So,
Um, so you can do both roles. We have an opinion from the PAC board, and we have a policy to align with that opinion, which is you shouldn't be the supervising provider and the advocate for the same patient, because it's sort of like you're saying, I deem the patient eligible for my services. There's no external check. We have our policy does allow for the scenario where there is no other available advocate and you have to do it. You have to do both roles. But we will inject a sort of external check to avoid the compliance risk or ethical risk that the PAC board has rightly identified. The other thing is that sometimes some of the work the provider does is billable. So you might be operating, you might be the supervising provider and there's no compensation for supervision past the initiating visit. We do compensate providers in our network for some tasks associated with that supervision, but CMS doesn't pay for, there's not like a billing code for supervision. But sometimes the provider is doing work in service to that patient that is billable. So it's possible. That's a bit different than um, sort of the PAC board caution against self-referrals, basically, or the risk of self-dealing is what we're trying to avoid with that policy. That said, it will not be a very exciting or lucrative rate for a physician if you're able to charge kind of top shelf private rates. You will not find these rates for the advocacy work very attractive, but it's available if you want to do it. So you could do either or both. Our uh, number one sort of path is not to do it for the same patients, if that makes sense.
Stacy asks, any barriers to maintaining independent advocate work with some clients while participating in Medicare services agreement to provide services to Medicare clients via Umbra? So basically, can I see some
Yeah.
folks through Umbra as Medicare and then also maintain my private practice? I mean,
Yeah,
the answer is yes, but
absolutely.
I wanna,
Yeah, the answer is absolutely yes. There's nothing inherently conflicting. One of the things we observe at AFA is that it's kind of hard to make a living until you get going. And sometimes even after you've gotten going, it can be a challenge to, fill your practice. And so folks do tend to take a variety of roles, maybe a little pro bono and some paid clients and some consulting work. And so it just, it seems very common to have a portfolio of work or a portfolio of clients. And this fits into that. It can certainly be just one source, one channel in a diverse practice. That said, I think there's one caution, which is, there are rules against balance billing for Medicare and Medicaid patients. So what you cannot do is get X dollars from us to see a Medicare patient and then bill them the difference between what we've paid you and what your private rate would be. You have to, when you see Medicare or Medicaid patients, you have to accept Medicaid. We're not offering that yet, but it's the rule that applies to those programs. So if you accept the reimbursement, you have to accept it as payment in full for those services. Now, you might do other services that are not covered under these codes, and those could be billed privately. We, in general, would say treat a Medicare patient like the Medicare rules apply and keep your private patients separate. But there's nothing in here, there's no conflict between having both kinds of clients.
let's see. Should we move on and then address more questions?
Yeah, I just saw a question from somebody about if you bring your own patients, do they get matched back to you? And I want to say yes. So the only um that's the point, right? We want you to be able to bring your patients, serve them, and just sort of use us like an extension of your practice, or vice versa. For these patients, you join our practice. That's technically what's happening, but conceptually, it's like we want to enable the expansion of your practice and your services. So if you refer a patient in and you want to keep them, we will match them back with you unless there are a couple of scenarios where we will not. And that one is if they don't consent to that. So that's unlikely to happen, but it's possible. So they say, oh, Claire brought me, but I don't want to stay with Claire. She asked me too many questions. I'm making that up. She asked me too many questions. I'm mad at her. I don't want to stay with her. I want somebody else. Um, that's probably a red flag anyway, but the point is the services are always under the patient always has to consent to services. We're never going to force something on them. So they could say, I want somebody else. Fine. We'll talk to you about that. We will not just yank someone from you. We will have, we will respect the patient's wishes and consideration for confidentiality. But we will not just sort of reassign without a communication with you. The other scenarios are if you're in a state where there's a very specific requirement for a credential and you don't have it, we will address that with you. I know the person who asked this question has a BCPA. We believe that credential works in every state, so that wouldn't be an issue. And then finally, there are some Medicare prohibitions which we have to pay attention to, which are things like you can't get paid to provide these services to someone in your household. So things like that would be limitations, but those are very either unlikely or very specific, and it's not. Otherwise, we're super happy to make that match and just you've made the match already. We're just enabling it.
Polly's asking, might there be some services that are not covered by Medicare that an advocate would bill separately for beyond the Medicare covered services?
Yeah, I think there are scenarios like that, and um, we would probably ask, we would, I think what we would say is we would work together to really test that and make sure it's very clean because compliance I say it every chance I get, but compliant, we take a strict compliance standpoint. I don't want to go to Medicare jail. I mean, I really, really don't want to, and I don't want anyone else to get in trouble with Medicare. So, um, I think it's it's and I am now a board certified patient advocate. So before I would say we align with or we support BCPA ethics. Now I am uh, obligated to live under BCPA ethics. And so there are certain ethical frameworks that we just will not violate for those reasons. And so um, I would want to make sure we're very, very clear on, are these services really different and distinct, or is it a gray zone and it's just I know, Polly, I'm not accusing you of this, but it could be like a sneaky way or a loophole to get paid more for services that we provide. We will not endorse that or allow that. But there are certainly services that are clearly distinct. And I think there are ways to do that that are completely legal and compliant and patient driven and patient centric. So yeah, I think that's possible. Delicate though. So
Is billing
Deb,
support?
I'm sorry. Can I just follow up with
yeah,
that, Deb?
please. Yeah.
Okay, I'm thinking of a case where like you're helping someone like pay their bills or get in touch, or like even do some like grocery shop, not even
Yeah.
just grocery shopping,
Yeah.
but they needed something
Mhm.
clothing wise that they don't have, and then you're going to
Yeah.
their house to pick it up, or you're going to shopping for them, or like really like just ancillary service, like you're doing their mail every day, you know what I mean? That kind of thing.
Yeah. Yeah.
Those are the kind of services that I don't think Medicare would be paying for you to
Right.
open their mail, but
Yeah. No, their Medicare is not paying for anyone to open their mail. I think that's a good example. Um, the prohibition is against balance billing. It's that I believe it is that rule that governs what I'm saying. So it's like if it's kind of like leftover stuff, like leftover money that you wish you could get paid, no. But if it's really distinct, like never covered, what you're saying is never going to be covered. It's not really even a healthcare service, even though um you you I don't think that would qualify as community health integration service. But again, in the specific instance, we'd want to look at it. It's possible it would be billable and legitimate under Medicare, in which case we'd run it that way. But I think what you're describing, and I think there are probably lots of scenarios we could come up with where, um, you know, uh, I know folks sometimes I hesitate to use this example because I don't think it's a optimal, but some people do provide transportation. Like I would be very, very careful about that. And we do not provide transportation, but that's an example, that might be it's a bad example. Let's think of others. I think opening mail is a good one, Polly, because there's no way Medicare is paying for that.
and I mean, down the road, this would be something that maybe Umbra could come up with a list of, like when people have this kind of
Yeah.
conflict thing, come up, talk about it, and come up with a list. So down the road, people could say, oh, yeah, these services would not be covered by Medicare.
Yeah.
And then it might be clearer at that point in time, too.
Yeah, we
So.
can, yeah, that's a good point. We can certainly articulate that more specifically. And we're always here to sort of chew on vet specific issues or specific ideas.
Do you have someone at Medicare that you can run these questions by?
Um, no, not one person at Medicare. Medicare, I will say it's a federal program, obviously, but it's actually administered state by state, which I didn't know until I started this process, how different it could be. The same rules kind of apply up here, but every state has an administrative contractor and they sometimes interpret rules differently.
Hey, Dad, this
Yeah.
is Ian Clark. You're going to jump in if you don't mind.
Yeah.
They're actually managed by what they call MAC, Medicare Ed administrators, and
Yeah.
each state is uh, separate.
Yep. That's what
So
I'm saying.
with that said, that might be a worthwhile discussion to have to build on this to show what it looks like nationally because they don't go in states. There's, 6 states that go together in the Carolinas. You have the Northeast, Florida is a standalone. Um, is that something you
Confusing.
folks feel would be a worthwhile discussion?
We're happy to inf sort of how to put it. We're happy to provide education or information as we understand it or based on what we know. But I guess I don't know how much folks need to know about that to participate in the program. So that's
Right.
kind of when I say like we've built this infrastructure, we do have there are maps and grids of MAC, so the Medicare administrative contractors, one might cover 2 states, one might cover 7 states. As Ian
Correct.
said, California is split, so one covers one and one covers another, or they're different parts of the same MAC. It's very complicated. It's very convoluted. They're all actually administering or implementing the same federal rules, but you
Mm,
enroll a practice at the state level and that state is part of a MAC, and the next state might be part of the same MAC. You still enroll it separately, and the next state might be part of a different MAC, and you still enroll it separately. So it's very convoluted. It shouldn't matter. It matters on the
okay, perfect.
billing, and it matters on the sort of opening up the states in the enrollment side. Uh, it matters in some workflow kind of situations for the back office or back end. But I don't think advocates need to work.
We don't need to get that much in the weeds.
I don't think so. If
I would.
folks are interested, obviously I will talk about any of this. I find it fascinating. It's like a giant puzzle and like 17 dimensional, it's like a 5-dimensional checklist, which really says a lot about me that I think that's fun and entertaining and exciting, but I'll leave it to the crowd, the wisdom of the crowd to say if this is a topic that folks want more depth on, we're happy to provide it. But it shouldn't
Excellent. Thank you.
affect anyone's ability to participate.
Do you want to just address the Medicare Advantage? Because some folks are saying they're trying to get services for folks on Medicare
Yeah.
Advantage and being told no benefits exist, or what's the
Yeah,
deal?
so Medicare Advantage, about half the population, half the Medicare beneficiaries are on a Medicare Advantage plan. Those plans are a, they're managed care and they are private run by private companies. Um, they cover they provide all the Medicare benefits, but in a bundle. And so technically, if a service is covered by Part B, which these services are, they are also within scope for the MA benefits that a patient would have. However, we do not currently have contracts. So you can enroll with Medicare. I've just described it. It's not easy, but it's like if you're a provider and you're set up correctly and you have the stamina to run the gauntlet, you can enroll with Medicare and serve original Medicare patients. If you want to do that for Medicare Advantage, you have to get a contract with the Medicare Advantage plan, and we have not yet tried to do that. So it's on our list because lots of people have Medicare Advantage. But it's not true that the benefits aren't there. It's just that we are not in network to provide those benefits. And in most cases, or in many cases, an MA plan will only cover in-network services. It's like they're not all HMOs, but many of them are. So it's like that. I hope I've answered the question. I didn't read the question, so if there are more dimensions to it, let me know.
I think I sort of combined a couple there. We'll see.
Okay.
Do you want to talk quickly about the communication between the advocate and the supervising provider? How frequent is that? Are there mandated touch points?
Mm-hmm. And I can, if Abby's able, I could not do all the talking here. I could turn it over to Abby, but it's asynchronous and it's through our platform. So there are notes, their charting notes, their visit notes, their care plan updates. And, if the provider is doing the visit, we're capturing the provider's notes. Those notes are accessible to the assigned advocate, so they can see, well, the provider wants the patient to get XYZ attention on these issues, and the advocate uses that input into the development of their plan with the patient. And then it kicks back to the provider for sort of review and sign off. So it's pretty much asynchronous communication, and unless there's a need for a live, an escalation point or a live conversation. Abby, are you there? Are you
I'm here. Yeah,
chiming
there's
in?
also the chat function through the EHR. I see advocates and providers working together sometimes for quick questions back and forth. Um, and there have been occasions where maybe they needed to have another live session collectively with a patient to all get on the same page. Sometimes that happens too, but mostly it's what you said, Deb, with the notes and the care plans and care plan updates.
So it's like you're part of a team, but it's not very heavy-handed. It's not like you're checking in every day. It's like your work is visible, and if you need support, it's there for you.
All right, let's just bump ahead, and then we have some other questions about providers and stuff like that. But let's talk a little bit
Yeah.
more about our approach, and then
So yeah, and I've probably said this all or most of it already, but I want to reiterate it. It's really important to me and to us that we remain committed to supporting independent advocates who want to participate, independent and otherwise, right? So kind of to advocates of all stripes who want to participate. Our program does allow for flexibility and choice. You can join our platform only. You can join our platform and others. You can join our platform and maintain your private practice. We have folks who have jobs. That makes it a little harder to schedule, but we're not we're not requiring anything of you other than if you accept a patient, you'll serve them well, and you'll follow our protocols, our policies, and the general advocacy, ethics, and CMS rules. So it's sort of like, however you want to dip into this, we're happy to have you. As we grow, we do think we'll be able to keep people busy full time. I don't think we're there yet, but and we want to share opportunities, but across folks, but you can do it however you want, so long as you are doing it in a compliant and ethical way. We have first and foremost, these two things, like unwavering allegiance to the patient and strict compliance, actually go hand in hand. If we're violating CMS rules, we get kicked out of the program, I go to jail. We're not helping that does not help the patient. But I would say these are two, extremely important top priorities. I know you can't have two top priorities, but I would like those to coexist at the top of the food chain. So my understanding of and commitment to BCPA ethics is that and independent advocacy is that first and foremost, we have allegiance to the patient. And there is nothing, we have poured over the rules and dug into the processes and all this. We don't see any reason why that commitment, allegiance to the patient, is at odds with the CMS rules. CMS rules, second bullet point, strict compliance, require patient consent at all times. Allows the patient to withdraw that consent at any time. Valid services, certainly the services have to meet the code, the definition of qualified service, but the primary definition is like it's valid and necessary. And we, as BCPAs, and not everyone here is a BCPA, and you don't have to be, but again, we always try to live to, even if we're not, even folks who aren't, even before I was certified, we would still always say we try to live to the BCPA standards. They're actually ethical guidelines you're not supposed to bill or do or charge clients for services they don't need. Like, so there shouldn't be any extraneous or inflated time or service delivery. So that's very consistent with compliance with CMS rules and BCPA. There's a lot of overlap. I've already said we really respect advocate choice. You can join in whatever capacity, and we respect advocate autonomy. We've set this up as independent contractors. That is both in recognition of and requires of us to respect advocate professionalism and autonomy. Now, we do have a set of standards we expect people to live up to, but we don't tell you, what time to do your work or where to do well, we do say you have to be in the US, but beyond that, you could be on the beach or you could be in your office. And hey, if you can work from the beach and have your toes in the sand, that's great. So it's like the things that make you an autonomous professional, we respect that. And then, like I've said, I've probably beaten this to death, but however you want to practice, we want to support you. If it's this program, wonderful. If it's not this program, wonderful. We have lots of education, lots of programming. We are trying to raise awareness in the world that patient advocates exist and to create or help contribute to creating meaningful opportunities for advocates to get work and income and practice and community. And whatever that looks like, we are here to support it.
So Deb, there's some questions about how this works with coordinating, or does this process complicate coordination and possibly duplicate efforts when the patient has a PCP? And how is the PCP included in the process? Are they made aware that an outside supervising provider is overseeing these services? What if someone in that practice is also providing billing for these services? How do we how is the PCP kept in the loop? I think that was a important question.
Those are good questions, and I can answer some of them. I also, Abby, if you feel like you can answer some, I would love to turn it over to you because my voice is telling me I'm talking too much. My throat is dry and sore from talking too much, but I do just have to make a snide comment, which I hope you guys take with a little bit of humor, which is like, wow, do people still have PCPs? Because I
Hard to find.
barely do. But anyway, no, this is a really good set of questions. It's really challenging because actually only one provider can bill for a patient in a month. And so if a PCP is providing these services, we actually can't. And CMS does not want there to be duplication. In fact, the whole purpose is to improve coordination of care and reduce silos. So this is a hard thing. Abby, I don't know if you could speak to we don't have perfect information, so we don't always know, and we don't always know who the PCP is. We don't always have consent to share back with the PCP. But maybe, Abby, can you speak to any of this coordination?
Yeah, I mean, we start by talking to the patient around what they're getting. Obviously, that data is self-reported, so it may or may not be accurate. But the patient has to consent to getting the principal illness navigation or the community health integration services. So we're starting there. A lot of times what the advocates are doing is care coordination. So they're working with the PCP and reaching out. Right now, we've been focusing a lot more on the PIN and CHI services instead of care management, kind of letting the PCPs lead care management services, even though that's something we could be billing for, to kind of not create duplication, because it too is a certain set of services that can only be billed by one billing provider per month. And we have not run into any duplication to date. We are still early in this endeavor and just getting started, but right now, most of the PCP offices are busy. They do not have the staff to do this, which is why we're able to bolt on and support. But it is not our intention to take services or revenue or anything away from a PCP's office. It's really to better augment and care for the patient. I would love a back end that would show me who's already billing for this, but it doesn't exist. So
there are health information exchanges, but they're highly imperfect. Sometimes the patient's issues, what they need help with is sort of reflective of either a problem with the PCP or a lack of access. And so that's kind of why we're here, but it's a really good set of questions. And thank you for indulging my snide little soapbox moment about, I had a journey to get a PCP and I don't really feel like I have one. So we have a shortage here in
All right,
Massachusetts, as everywhere.
I moved us to the next slide, but first I just want to say I saw in the chat Heidi from the PAC board say that CMS has confirmed that BCPAs are considered qualified to provide the auxiliary services, I assume she means.
Thank you. Yeah.
At Umbra, we do not require folks to have a BCPA, although we do support, endorse, encourage. Is that
Yeah.
the right word?
Yeah,
Right phrase?
all
Yeah.
of the above. We are BCPAs. We're very proud of it. We've always endorsed it. Now we're in the club as well. We don't require it. We do know that it takes all kinds, that lots of folks can be qualified without the credential, or many of you are working towards the credential. Some of you are avoiding taking the test I'm just kidding, because I was you just a few short months ago. But it's it's a really, I really understand sitting in this seat, running this service now. I understand how valuable the credential is, because when we say like we have a board certified patient advocate for you, it really kind of, even though I know many of you who don't have the credential are that same caliber, it's a signal to the world that we take this really seriously and that we have signed up for a set of ethical codes and principles. And so it's helpful to us to have BCPAs in the mix, but we don't require it, as Claire said. And thank you, Heidi, for saying what I said less. I said it less firmly and less clearly, but my understanding was based on what you've told us, which is that CMS recognizes the BCPA, and so it kind of it I want to say trumps, without being political, it sort of trumps any other requirement, right? If a state has a CHW certification requirement, that's actually a lower threshold. The BCPA exceeds that threshold, and so we're safely over it. And that's why I kind of glossed over, most states you can operate anywhere as an advocate, especially if you have a credential like the BCPA. So this slide, I think we've talked a lot about this, and I've sort of editorialized somewhat and shared Umbra's and AFA's view on a lot of these things, but at the end of the day, true to our values and our ethics, we respect advocates and obviously providers as well, but we respect independent advocates' decisions whether or not to participate, and if so, how. And so some of the considerations that an advocate might want to consider are here listed here, like does participating in Medicare, we heard this a lot maybe in the fall, like a lot of discussion about does participating with Medicare violate the allegiance factor? We don't think so. In fact, we think CMS rules kind of align with and endorse the allegiance factor. Does it change your independence? Well, if you take money from any entity, you're sort of answering to somebody, you're getting paid by somebody. I don't personally think that means you're not independent, you're not an independent professional. It just means you do work within a structure. So there are differences, but but sorry, I still am editorializing. Actually, it's totally fair to say that doesn't feel independent enough for me. And, that's fine. I think we don't mean to curtail your independence as a principle, but obviously when you work on anyone else's program, you have to live with those rules or standards. So there's something about that. Rates and income. Some people don't get paid, or haven't gotten paid yet because they're just starting out. This would be a great way to get paid for some of the work you're doing or you know how to do. Some people get paid a lot, and this would not be a good way to get paid. And so it's really up to you, and no one can tell you what's a good, what you're worth or what your time is worth or how to spend your time or whose money to take or how to take that money. That's so personal. And we do not pretend this is like a great income opportunity for everyone, but it is an income opportunity and it is available to independent advocates who want to take part in it. The regulations are a consideration. As I've said, compliance is really, really important to me personally, and it's embedded in everything we're doing. And we are designing our workflows, our charting, our billing, everything, and our policies to sort of enable the right thing to happen. So I've seen some things on other platforms where, there are extra incentives if you do more hours. Well, that is great if you're doing the hours. I personally think that's challenging because it's creating an incentive to do more. Like it creates an incentive to do more time. Patient may actually need more time, or there might be more patients who need time. So that's all good. But any incentive or any step that moves you away from like a compliance standpoint or stance makes me anxious. So we're, trying to enable the right thing. So we're trying, it shouldn't be onerous to everyone else. It's our job to make sure our systems are set up in a compliant way. The navigation codes themselves are very broad. That's part of why I had to pause on Polly's question, because there are just a lot of things you can do legitimately inside these codes, but not everything. So there are some constraints. And then role clarity, somebody raised, if I'm a licensed clinician and I'm an advocate, can I do both? How do I do it? You can do both. You can do one or the other if you have that licensure. It's the intersection that we want to be careful about. But we have ways of working through that with you and again, enabling the right thing to happen by not assigning you as the advocate for patients you might see as the supervising provider. So it's really up to you. There's lots to think about. Lots, and we're happy to have you join us a little bit or a lot. We're happy to answer more questions, and we're happy to be here to support patients who need us.
So one question, Jan is leaving, but she had a good question about do we have information or marketing materials for Medicare beneficiaries
We
that she could
do.
give out to
Yeah, we do.
like a flyer? So yeah, maybe we can distribute that to the folks who were here today if we have any materials that they could use to
Yeah.
give to providers or to give to potential beneficiaries. And then there was another question just around Nicole's asking, can we discuss the difference between PIN and CHI services and comprehensive private independent healthcare advocacy services? And I mean, we kind of touched on it, but just the
Like the difference of what the services
services.
are themselves.
Yeah, I think there's a lot of overlap, right? But there's definitely when you're doing a private independent advocacy, the sky's the limit kind of in terms of what you can
I
offer.
mean, in a
In
way,
some,
but I
but
don't know if
still,
I'm
well,
thinking
because
back
some
to the scope
advocates,
of practice. I don't know if that's really true. The sky's the limit. Like, I think there's a high degree of overlap. I would have to
yeah,
look, I think we'd have to chew on like an edge case to say, is this like, or just go through tasks like is opening your mail, somebody's mail,
right.
a
But in
qualified.
terms of like, there's no cap on the hours, so that's one difference.
Mhm.
Um, yeah.
Yeah, I think it's a good question. I think it's really hard to say how they're different. I think that I guess what I've been trying to say is we're trying to operate the service within the scope of practice that you would adhere to.
Following.
Yes, so CMS is more flexible. Like if a physician is the supervising provider, they can also be the auxiliary personnel or provide those services, and flip between those. But in the patient advocacy ethics, that's not okay. So we are trying to take that stricter kind of advocacy oriented lens to it. CMS is actually in some ways more flexible. So I don't know
Yeah.
how different it is. There probably are differences but I don't think it's as a rule. I think it's there are specific things we'd have to look at. I'm sorry, it's not a great answer, Nicole.
Who tells the advocate the number of covered services or contacts for advocate services? Does that info come from CMS to Umbra to the advocate? Like, how do we know? How does the advocate know how many hours or visits they get?
This is where the ethics really matter so much. It's about what does the patient need. So there are some
There's some
guidelines.
cap.
There are some, well, we have imposed some caps because we know that Medicare has what they call medically unlikely edits. So if Medicare thinks you've spent too much time on something, they can deny it. We can appeal it. But so we're trying to, test that and think about how much more do you really need? Do you need 8 hours in a day? Medicare thinks probably not. But we know for sure there are times when you need 8 hours with a patient or on a patient's behalf in a day. So there are some guidelines. There's not really a hard cap in the codes themselves. But we have
I'll
some
pull up the
policies to protect against sort of overusage, inflation, and also denials. But if we have to appeal for a valid reason, that just means we have to have very good documentation and justification. It doesn't mean it's not qualified.
Steph is saying in the chat, the number of hours can come from the initiating visit, the advocate in-depth assessment and care plan that can be documented to align with the work. That's a good answer.
Thank you. Yeah, it's
I just
which is like not unlike what you would do with a private client. You would scope the engagement, understand their goals and needs, estimate the time. A lot of private clients will have a cap because of budget. So in some ways, these services might be more flexible, but they still should, the service limit should be dictated by what does the patient need. That's always true.
Right, I put up the FAQs for folks to read. These are just some of the questions we were getting in the beginning. I know we're a little over time, but I just wanted to give folks a second to read that. Any other last thoughts, Deb, before we wrap up? Or I hope I got all the questions. It's moving pretty fast. I think there was a couple I think I missed, but feel free to email us.
Yeah, we're here. I think that's it. If you show the next slide or the prior slide with the contact, like just get in touch with us. There's a lot of stuff to think about and talk about. And I would just say these services, the good news about the Medicare codes is that it is breaking through. People are understanding, awareness is raised that services are available. That's good for everyone, whether you participate in Medicare or not. I think that is a really good forward progress on awareness of patient advocacy services. And we think we observe in our volume that it's kind of rising, the rising tide lifts all boats. We think as more people understand these services are available, some will fall into the Medicare category and some will not. And those folks will still need help. And some of them will be able to afford a private advocate. We will be here to support that as well. So thank you. Thank you for listening. Thank you for coming to my TED Talk. Forgive my editorializing and my overexuberance. It's pretty exciting, and I love to see advocates all the time. So thank you for coming. Please be in touch if you want more info or if you have issues, questions, ideas, excitement, anger, whatever it is. Feel free to chime in and let us know.
Yes, thanks so much, everybody. If you are an ALPHA member, this will be posted in the live call-in webinar page history, and along with the PowerPoint presentation. Feel free to email me too if you need any other resources or want more information on any of this stuff, or you can email Medicare at Umbra Health Advocacy. It's there on the screen. So thanks everyone for joining us. Have a great weekend. That's it.
Thank you.